these messages home, especially those who are from the rural areas. This thing has still been practiced. I call it man's inhumanity to man. It's absurd, it's wickedness. Anywhere I stand and I see any lady or a girl about to be cut, I will beat the man or beat the woman very seriously. Honestly, this is painful. I'm not even putting myself in their shoes. Imagine the trauma, the pains they go through. May God help us. Please, you are the change agents. You are the you're the ones that will be, the change agents. Take these messages to various homes.
We'll take a quick. We'll take Dr. Rabi's presentation quickly, and this is still in line with the female genital mutilation thing. So please give us some time. After Dr. Rabi, then we'll invite Dr. Comfort more. Dr. Rabi, please. I need to stand close this way because of the speakers. Thank you. Can we applaud her, please? Thank you so much. From UNFP, by the way.
Good afternoon, all. Let me just start by telling you I will not be as interesting as the last speaker, because I'm a very shy person. So, my colleague was doing the presentation. She kept showing me faceless pictures, and it looks like, my God, where are these women? So very soon now, we will know where the women are, what states they are in. So let's remember our states and look out for our states as we project these slides. So this is on the situation analysis of female genital mutilation assessment conducted in 6 states of Nigeria. Next slide, please. Next. So I think we should just move to the data. So this chart shows the trend of female genital mutilation in Nigeria. We carry the medals for maternal mortality and child mortality. Our sisters and brothers in Southeast and Southwest, they will carry last. They will take this one. So this is the trend. You can see Southeast and Southwest. To be honest, female genital mutilation happens everywhere in Nigeria, in every state. Even though some cases may actually be underreported and it may just, be swept under the carpet, but it's a reality. So, so we conducted the assessment in 6 states: Ebonyi, Ekiti, Imo, Lagos, Osun, Oyo, and we came up with an average. That is the NDHS. If you are from Osun, just say, I am proud and I'm from Osun, but we will stop it. You can just say you will stop it. Thank you very much. Evidence for action. Do you want to get up and say you will stop it? Okay, so you can see Osun is very, very high, and honestly, I must say that there is a lot of political will from Osun State government. The wife of the governor of Osun State particularly led, a big program around ending female genital mutilation. I think she launched the campaign sometimes last year. So Ebonyi, Ekiti, I think the second highest is which one there now? Ebonyi. Okay, Oyo. Yeah. Which one? You see 83.9%. Then in 2008, but the most current 2013, you can see the next position there is Ebonyi. But you see all those in the 70s means, it's a lot. That means if you take 100 women, you find like 70 something. Even in WAEC, 70 is distinction. So it means almost everyone. So it's really a source of concern for us, particularly looking at all the complications. And you also know that Nigeria is among the countries with the highest prevalence of obstetric fistula, the vesicovaginal fistula, the VVF. So most of these women who end up in prolonged obstructed labor, who have no access again to cesarean section, come down with obstetric fistula. So high prevalence of female genital mutilation, 24.8% at national level, especially most endemic states, according to the NDHS in the slide I had shown to you. So like we said, the data is scarce on prevalence, knowledge, attitude and practice, and on the social norms around FGM at the local level. So we are trying to drive more community-based programs to understand the community dynamics that drives this problem. Next slide, please. Next slide. So I think it's what we had projected before. So this is the preliminary findings, and we can see the results there, like we just projected before. Osun again has 76.3%, Ekiti next 71.2%, Oyo 69.7%, Ebonyi 55.6%, Imo 48.8%, as well as Lagos. So if you calculate this and put against the population of these states, you'll see that we are talking about millions of women out there that have been genitally mutilated. Next slide, please. So again, this is just the analysis by LGA in the states. Sorry, I would worry you again. The man from Osun is your LGA then. He's my friend, that's why I'm just. Okay, so the next slide. So it's just the same thing. So I think this may just end this presentation because we had talked about most of this. It says, why is FGM performed? Sexuality, marriageability, economics. FGM is an income generating activity and improves status of power. I wonder how true that is. I doubt it. So then again, tradition, preserve handed down from one generation to another without asking why. So again, we have right of passage to womanhood or girlhood. That is when some people do it maybe at menarche or just before marriage. Then religion. The previous speaker is a Christian, but I'm a Muslim, and I can also categorically tell you that in Islam, women are not supposed to be mutilated. It's not written anywhere. Okay, so cultural, aesthetic reasons, and then myths and beliefs. Okay, some communities believe that the clitoris contains power strong enough to cause harm to a man's reproductive organ or to damage or kill a baby during childbirth. You would be amazed, you know. So next slide, please. So our recommendation is for stakeholders to intervene, to address the area, to address the reasons why FGM is performed at community level. Is that it? So please can all of us stand up and hold the person right beside you. Close your eyes and then say that we are determined to stop FGM in our generation. We must close our eyes because it is painful. And by the grace of God, all of us in here will carry our own granddaughters. People don't want to die. Amen. So thank you very much.
Thank you very, very much. I'm sure we have had so much that in our hearts there should be hatred for female genital mutilation. Don't we think so? Especially for the students. Tell your parents that it's not good. Now we want to call on Dr. Comfort Momo, and she's going to be looking at it from a very different perspective, because all that we've heard is about what's been going on in Nigeria. She wants to bring us the United Kingdom's perspective. Can we please put our hands together for Dr. Comfort Momo? Very smart.
Thank you so much. I know we don't have much time. While my presentation is being, yes, that's the word. Thank you. I'd like to say it's so, what's the word I'm looking for? At Lutz in the 80s, very early 1881, I trained at Lagos University Teaching Hospital, and I'm a product of Lutz. So I'm so pleased to be here. And also, thank you to the organizers for putting today on. So I'm really, really proud as a Nigerian, and I'm really proud to see you nurses and midwives really well smart there. Thank you. Most of the stuff have been covered, and as you can see, that's me. The next slide. And I work at Guy's and St. Thomas's in the UK, and I run a support service for women and girls who've been through FGM, which is very, very important. Yes, we've had the side effects, we've had what FGM and the damage can be, and why FGM is being practiced. But we really need to focus our attention to supporting the women. We as midwives, what are our roles in safeguarding girls and women who might be at risk of FGM? And that's what I want you to focus on. The next slide, please. And the next one, we'll skip some of this because of time. Next slide. And the next slide, please. Yeah, we know here, we've listened to the stats around FGM here in Nigeria. The next one, please. This is just to show you, I call this the Queen and I, just to show you the Queen knows about FGM, because I'm bringing the UK perspective. We've had support from the Queen, we've had support from all over in the UK, the MP, the Prime Minister, and support from other non-governmental organizations. So I've got this specifically to show you that there's a lot of support, and that is what we want as Nigerians, to commit to this support. I want our Nigerian Government, yes, we've earned FGM last year, but I want commitment from our government here, and we're going to pressure our government for this commitment. And also, I always have this because I truly dedicated all the work I've done around FGM, around women's issues, to women and girls out there. Women and girls who've been through trafficking, women and girls who've been through domestic violence. Truly, this is from the bottom of my heart. The next slide, please. And these are some of the work. This is not my first time coming to Nigeria. I was born in Nigeria, in Lagos. I grew up in Lagos before going to the UK about 32 years ago. And these are some of the work that I've always come back to do work here. This is in Taraba State. Do we have anybody from Taraba? I've done lots of work in Taraba State with the traditional birth attendant, just to show that. Then the next slide, please. Again in Taraba, working with the women, working with the men as well, because we need to bring the men to what we're doing. We need to invest in our midwives, and we need to work with the community. We need to work with our young people as well. When you skip this, these are the men that I work closely with. Again, some of the work that we've done in Chad. I find this really interesting because so when we went to Taraba State, I met a young man who was so interested in supporting the campaign, and he took us to his palace, and this is his palace, and I promised to put his palace on my slide. So again, he was really proud to join the campaign, and he was proud from where he is as well. Thank you. We'll just skip some of this, because this has been mentioned already. Okay. If you don't take anything away from today, please read this very carefully, right? Because in the UK, I work very closely with Nigerians, and most Nigerians, unfortunately, we are in denial. We always say there's no FGM, we've eradicated FGM 10 years ago. That's what I hear a lot from my Nigerians. Just read this. It says, I realize that my ties have been pulled wide apart, and that each of my lower limbs were being held pressure. I felt that the raspy knife or blade was heading straight down towards my throat. The next slide, please. Then suddenly the sharp knife metallic edge seemed to drop between my thighs, and these cut a piece of flesh from my body. I screamed with pain. That's why the tight hand held over my mouth. For the pain was not just a pain, it was like a shearing flame through the whole of my body. I would challenge my young midwives here, when you go out to the community, when you're reaching out to the families, think about this. This is what our girls are going through. And as Nigerians, as mothers, and as husbands, as the community, what are we doing to safeguard our girls and women who've been through FGM? I say women, because we've seen women at age 40 who have been through FGM. I've seen women from Nigeria coming to my clinic that I run, and they've been through FGM. For example, a typical one was a woman who had her FGM at age 40, and this was a punishment by her husband. Yes, because she had 3 children, but there was so much domestic violence, and she was leaving the marriage. She was trying to divorce her husband. She was fast asleep at one night. The circumcisers with 4 women came into her room, tied her down, removed her clitoris. And this is a fact. We saw her at the clinic about 2-3 years ago, and the problem now is she's now paralyzed, obviously from the stress and everything, so she's paralyzed as well. And my sisters that spoke earlier before me talked about FGM being performed just before you get married. Yes, in some communities, people perform just before you get married. My challenge and my question is, why women? Everything evolves around women. So, for example, when you get married, you're having sex for the first time, if your husband's penis touches the clitoris, he can die. You know what I say? Let him die. Let's kill all the men with our clitoris. Why women? Yeah? Yes, sorry men, but it's something that people really take seriously and say, oh, yes, this will happen. Why can't we challenge this? Yes, the next slide, please, quickly. Well, yes, we know FGM has been banned in this country. What are we doing? What structural stuff have we got here? The other issue, before I quickly conclude, is that I will really want us, especially those working around FGM here in this country, to look at very carefully on a weekly basis. I see 1 or 2 Nigerians seeking asylum on FGM grounds. And I write reports for them. And sometimes, obviously, most of the time, this asylum case fails. If they are sent back to Nigeria, I ask my fellow Nigerians, what structural place have we got here for these women and their family being sent back to the country? Do we have a safe haven for them? Do we have anything for them? Please, we really need to look at this. And also the psychological impact for some of these women and girls. Yes, we talk about it. Yes, we know the consequences, but what services have we got for women and girls suffering? Yeah? The next slide, please. We'll quickly skip on, because I think most of this has been covered already. Right, like I said, my question is, what are we doing as Nigerians? What are we doing as professionals? What are we doing as politicians? Yes, we ban FGM. Do we have anything in place? What are we doing as parents to safeguard girls and women who are at risk of FGM? And selling of clitoris. I was here about 2 years ago with Auntie Efwa. I'm sure some of you know Auntie Efwa. May her soul, whenever I mention her name, I feel really emotional. May her soul continue to rest in peace. I've worked with Auntie Efwa for many, many years with WHO and in other countries. And we were here about 2 years ago to do a scoping visit, and we were so shocked that people were telling us that they sell the clitoris. Yes, they sell the clitoris, and this is a fact 2 years ago. And why do they sell the clitoris? You buy the clitoris. We need to be working with the witch doctors. You know, with the witch doctors, the man albinos, limbs, albinos, legs, and all that for ritual. So what are we doing about that? Next slide, please. Again, my work here in Nigeria. This was when we went to Taraba. Again, we still have challenges, as you know, with mothers still being taken in carriage like this to the nearest hospital, and this is still fact. This was just about 4 or 5 years ago. Yeah? Next slide, please. We'll just skip all this quickly. How am I doing with time? This is the clinic that I run at Guys and St. Thomas's. I actually established this clinic with the help of colleagues here, which are in the front row there. And the clinic started in 1997. We see, this is like 18, 19 years ago now. We see pregnant and non-pregnant women. And obviously with the midwives, the pregnant women, we have to identify them earlier on in pregnancy so that we can provide support and counseling that they need during pregnancy and labor and post-delivery. But if you need to talk to me later on, we can have a chat because I'm so much aware of the time. Yeah. And also you've seen this. This was some of the women that we saw. But what I want to show you, the next slide quickly, the next one, is these big democysts that I actually saw at my clinic a few years ago. Then the next one. And we had to take this woman to the theater and remove the cyst immediately. Again, the next one. And that's what it looks like once it's been removed. Then the next one, please. Just to bring it back to the women that I see in the UK, as you can see, I do get lots of emails, lots of text messages, and the women have access to me 24/7, and this is my choice. And I know my husband has given up on me, but it is my choice. As you can see, their comfort. I hope you can assist me, and blah, blah, blah. It's just we need to bring it back to the women, which is very important. The next one, please. Again, you can see this person, apart from the FGM she has, she's getting married to another community, another culture, which is a big, big problem for her. Again, are we as professionals addressing these issues? We are not. The next one, please. And again, dear comfort, this is the lady you operated on, because I do defibrillation. I do average of 1 or 2 every week at my clinic, and I train other doctors and midwives to do the same. Yeah. Again, the little things, and I'm sure you midwives know that, like when you have a woman coming to give birth, the little advice or the little support you give to them goes a long, long way. And also the attitude and our behavior obviously goes a long way. So again, it's important that we are aware of this. The next slide, please. This is the one I just received just before I came. It's just, I'm just showing you all this just to think about the women themselves. What we are putting our children through. Yeah? You see, and these are the campaigns and the leaflets that we use in the UK, and we take the law very seriously in the UK. There's 14 years imprisonment, and we need to be telling our families all this. Yeah, there's more. And that's me, and what obviously I want. I'm in my 50s, I'm still hoping that FGM will be eradicated or end in my lifetime. I'm hoping that for God. And this is the fight that I will continue to fight. And thank you. And then first I'd like to say from our government, the next one please. Sorry, I'm rushing because I know it's the next one, please. And then it's about working together, it's about collaboration, it's about reaching out to the community, it's about working with our young ones, right? I would say my heart now is empower them, because they are the future generation in everything that we're doing. So it's very important. Next slide, please. Pick up for 1 or 2 more, and I will be quiet. And obviously, for conclusion, this is what we want. Yeah? And the next one. Next slide, please. And the next one. Yeah, every child matters, which is the key. And then the last one. Oh, I'm the last one. I think I'll stop here. Be the change you want to see in the world. Thank you very much. Because if we say we want to change the world and we're not doing anything, nobody will do it for us. Thank you so much.
Thank you very much again. You've all done well. I'd like us to do just one clap exercise. Thank you. All right. Now, because we're almost coming to the end of today's session, we have 2 minutes for some contributions. First will be the abstract presentation, postnatal family planning practice, and the influence of the factors among Nigerian women in southeastern Nigeria. Oluchukwuobiora, is she here? Oh, please, come forward, come forward. We'll bring all of you to the head table. In the future,
future leaders. And then we have another presentation by OSCE as a
training tool by Grace Oyakure. Grace. Woman-centered care and work. Ma Ofili. This is Ma here. A round of applause for her, please. Antenatal, postnatal education. Kids, Anolwe. Is it Kids, Anolwe?
Yes, please.
Thank you, you're most welcome. Let's give them another round of applause. And this is like to say something.
We are going to have lunch, but after the presentations, I just thought I should let you know what the plan is. You're probably thinking, when are we going to talk? Great midwives! Great midwives! And I've had handsome midwives! Thank you.
We are very few here. But truly, lunches. Immediately after these presentations is lunch, and we are giving them 33 minutes as against the initial 5 minutes. So we take 33 minutes each. Now, when someone saw FGM, as I was talking, he said, federal government money. I said, no, we are talking about female genital mutilation. It's a very serious issue. Let's put our hands together for the women. We'll start in the order which I called. You were the first to be called man. That's nice, so we can take Madam Anolwe.
Hello, good afternoon, everyone. I'm sure you're very hungry, but obviously today is a wonderful day. The day that we remember all women and all girl child. So I'm so proud to be here. And can I just say thank you very much, Felicity. And obviously Toyin is not here, but it's amazing what a wonderful thing she's done. Because this is the first time we've got, the International Midwifery Day in Nigeria. And I thought I must be part of it. I'm a very, very proud Nigerian that live in London, but I've never ever forgotten my country. I'm always proud of my country. And I'm not going to talk a lot because I want to say to you that all the things that I achieved in London is all to the education that I had in Nigeria. Nigeria is my basic. I've practiced midwifery, or can I say, I've been a midwife for over 35 years. And I love women, and I came across a lot of women, a lot of women issues, a lot of women suffering. And I will never ever forget women. They are what I talk about passion. I've got passion for you all. During my military practice, I found out a lot that what women went through is not only having baby, it's about domestic violence as well. It's about you, the woman, not understanding the changes in her body. The reason why she has changed and become a different person. The hormonal changes that makes her different from what the man saw the day the man came to marry her. Hence, I thought it's better we start from basic. Basic. It's not just when she's pregnant before you start to tell her about what happens about pregnancy. And that is why I said it's so important to talk about antenatal and postnatal education. Can you move the slide so that I quickly and again? Okay. So what I did is just before I finished my midwifery, and I thought, do I go to sit down? No, I don't. What I want to do is to continue to give all my service and my skill to the public, to the women, first time months. First time months are the crucial, because if you've been to a river before, as you go second time, you know the pathways, then you know where you don't have to go. But when you go the first time, you don't really know. So I thought my knowledge and my skill should concentrate that. Hence, I have this tender care health initiative, and that's my banner over there, all the way from England. I carry them come. And there I've got, some of the women are pregnant, just a few of them to show you what it is that you have embarked yourself as a midwife. You don't give up. Because once you're a midwife, always a midwife. Even if you're not doing delivery, there are still a lot of things that you have learned that you can give to others. Sitting down to talk about, this is what happens to your body. This is what happens when you're pregnant. This is what, I feel that I want to go to the secondary schools, go to the universities, and start to teach them what it is to talk about pregnancy, to talk about having baby. It's not just jumping in and then, yes, I'm pregnant. So it's very, very important that this is why I thought the antenatal education before pregnancy, during pregnancy, is very, very important. And the way you approach the mothers is very, very important. Because mothers are afraid of midwives. They are afraid of midwives. Do you agree with me? Because not because you don't, it's because you know too much and they feel they don't know. They actually know a lot. The mothers know a lot. But the only thing is for you to embark on them, to show them a way that you two can work together. It has to be partnership working. If she understands you and you understand her, she builds that trust that she can sit down and say, oh, this is what is happening to me. And you know why I'm saying this? I came in December 2013, down Christmas time. There's a very, very rich entrepreneur that does health check every Christmas time. And I said, I'm coming to help. And when I did go there, I was there about 7 o'clock in the morning, and I walked non-stop until 7 p.m. And within that time, I saw about, there is all mixture of everything, but I saw about 6 pregnant women. The only thing, I didn't hear them, but while they were talking to me, the way I spoke to them, the way I had the listening ears, the way I explained the little things they said to me. When they got up, the first thing she said to me, Auntie, where is your office? I said, I don't have office. I actually live in London. He said, Auntie, the way you spoke to me, you just made me relax, and everything I can tell you, and then you're able to explain to me all those little worries. This is what the women want. The women want you to be part of them. The women want you to listen to them. The women want, even if they have baby load, if you have a listening ear, and that listening ear should start before pregnancy, during pregnancy. Let us have antenatal classes. Those antenatal classes, you can form a group of those women and sit in the middle of them and say, today, what do you want us to talk about? Throw it to them. What do you want us to talk about today? They might say to you, oh, I can't sleep. What do I do? And you find there's another one in there that will say, yes, I can't sleep. And the one will say to you, oh, I ate something yesterday and it's giving me a tummy ache. And then you can say, explain to us, this is the way you do, avoid this, or you prepare this in a different manner. So it is the way we approach them. We will be able to, because as I said, I'm a proud Nigerian, but I'm not too proud to know that 580 women died out of 100,000. I'm not proud. I'm not proud. And I know we've got lots and lots of money in the country. Why should it happen? Why? And we have 69 babies dying every 100,000. Why? There are plenty, there is money. Why? I get frustrated. And there are a lot of us that would want to come and help as well. And that is inclusive, including me. We want to come and help. If there is any way that we can make things better, we want to do that. The reason is because there's a lot of work to do. There's a lot of work to do. Because if your mother if you learn about things during your antenatal, that will help you when you have the baby. Because when you have the baby, remember all the things that, all the discussions that has taken part. You'll be able to remember that. You'll be able to remember that once you have the baby, it's not only the baby, it's not only yourself. This affects your family. There are family changes, there are initial body changes, there are workload changes. All those things make you to be a different person. But if you learn that from the beginning by having that antenatal classes, that will help you to cope with your baby. There's a lot to say. I must give a chance to everybody. But if you want to ask any questions, please don't ask me later. There's a lot of stories for women. Let us stand up for women. Let us work for them, and let us work for our girls, because our girls are our future. Thank you very much.
Thank you very much, madam. I know that there is so much in your slides, and I'm sure by tomorrow we'll be able to expand from your experience some more. But right now, I would like to invite, we're inviting, Olunchuku Obiara. Can we have you take a few minutes, please? No protocols, just go ahead.
Okay, thanks so much for the privilege to share our research findings in rural communities in southeastern Nigeria about postnatal family planning practices. The next slide, please. Yes, as a matter of introduction, we know postnatal family planning is all about the prevention of unintended pregnancies and making sure that the pregnancies are well spaced. Yes, we'll be told that we have high rates of illegal abortion in Nigeria. We'll be told that in Nigeria our fertility rate is about 5.7. The next slide already is about 5.7%, while in rural areas we have fertility rates as high as 6.3%. And Nigerian government, UNFPA, and many partners have done so much to help us to increase our contraceptive prevalence rates. But the truth is this: as we are here in Abuja, making suggestions, trying to deliberate and have and plan on how to reach out to these women in various communities, what is really happening there in the communities? The government have made available contraceptive materials at no cost, and many of these are being distributed to our schools, to our primary health care centers. But the truth is this: what's really happening at the grassroots? Why is our fertility rate? Why is the rate of illegal abortion still so high? That means there must be a socio-cultural or structural problem at the grassroots. Why are women not running to our clinics to tell us, I need to space my children, I just put to bed? That means there's something there. That's why this study was conducted in southeastern Nigeria. Let's go to the materials and methods. Because southeastern Nigeria covers a wide geographical area, we actually use a multi-stage sampling method. That's quota. And at the end of it, we chose Anambra State as the sample state. And then in Anambra State, we chose local governments, 3 local governments specifically. And go to the next slide. Results, the next slide here. The next slide. I would like you to take a good look at this table here. That's the result of this study, research finding we did. You will notice the first question the women were asked, were you thought about family planning? We are here saying yes, people know, people know about family planning. Can you believe that? In the southeastern part of this country, where we say yes, people should know, majority, a significant percentage of the women say deliberately that they aren't aware of anything called family planning methods. They only know about their beads, about their herbal methods. I mean in the grassroots, I'm not talking about cities. This one was conducted in rural communities, in villages, where you have enough of traditional birth attendants. Okay, then look at the second question. The women were asked, those of them that said yes, they are aware about family planning, they were asked, what are your reasons then for not accessing going for family planning clinics? Some said husband's refusal. Some gave various reasons, financial constraints, and many other things. This calls for need that for us to get to these women at the grassroots, not just to sit on our big tables, make deliberations, say the government is doing this person is doing the other one. That's very good, but these women at the grassroots, something is happening. Husband's refusal, their beliefs, financial constraints, and many other things. The last one, So we asked when they resumed coitus, that sexual intercourse after childbirth. Several of these women, based on that result there, said they resumed contraceptive use 6 weeks after childbirth. They don't believe they can get pregnant immediately after childbirth. They don't know anything about ovulation. They don't know that once there is ovulation, there is possibility of having a pregnancy. That's why there in these communities, you see a woman 4 weeks after childbirth, the woman comes 6 weeks after childbirth, the woman comes for postnatal checkup and she's pregnant. Let's go to the next slide. This is a pie chart. And they were asked, for those of them, they were not asked which family planning method do you practice. Can you see that 29%? They said they don't practice any family planning method that God gives children. In fact, some of them told us they believe that family planning is the white man's method to cut our fertility rate, to make us not to limit our population. We need to get to the grassroots. It's not just providing the equipment. It doesn't just end with training midwives. There is also need to develop media strategies, act plays, plays that not English plays using the local languages that will convince these women and even the males on the importance of family planning. The next slide. Then we now decided to check the factors. Using chi-square method, we decided to compare the factors like parenting, marital status, community of residence with their family planning methods. We wanted to find out those socio-cultural factors that limit the effective utilization of family planning clinics like these women. And look at the text, you will notice that this chi-square result, that parity was very significant there. It shows that parity is very statistically varied with their family planning methods. And because of time, I didn't put all the other many analysis that we did. During the analysis, we discovered that not just parity, husband's belief, husband's refusal, mother-in-laws, these women have lots of control over these women. You see, their mother-in-laws. Some of them say, my mother-in-law will not allow me, and all those stuff. That's why we need to educate these women. The next slide. Conclusion. We concluded from the findings in this research that ignorance is the major problem. If they knew the importance of family planning, if the husbands understand the importance of family planning, they will not stop their wives from going for it. If the elderly women understand the need and the value of splitting children, they will encourage their wives to go for it. If the faith-based clinic, the traditional rulers and traditional prayer men, get to understand the importance of family planning in saving the life of not just the mother of the child. Remember, the topic is postnatal family, not just postpartum, because here we are giving consideration to the child too. If they understand the importance of family planning to even their child also, the child, they will push their women to go for family planning clinic. The next slide. That's the last slide, the recommendation. We went on to recommend that there is still need to act family planning. As a movie, as a play, in whichever form, need to talk family planning. Need to get to these women during their many meetings, their traditional prayer meetings. For those of us there in the community like myself, get to their meetings, associate with them. If you stay away from them, they'll be looking at you from a far distance as distant midwife there. But when you come closer, go to their meetings, go to their festivals, it will give you a good opportunity to tell them the truth. It's not just the women, because we see that family planning is not just about the women. Involve the males, teach the males the importance, teach the elderly women. They will go home and tell their wives, woman, go for family planning so that you will be able to control and you will be able to take charge of your fertility. If we succeed in doing this, I believe our maternal mortality and our neonatal mortality rate will be drastically reduced. Thank you so much.
Thank you. It's not so easy, but you performed exceedingly well. There's another round of applause for Abuja and Kings and both done exceedingly well. There's another round of applause for our guys and please, I like you to please take a few minutes, please, but I'm not protocols. Thank you.
one very important tool in the training of midwife. I'm a midwife educator. I'm also very glad to the Nursing and Midwifery Council of Nigeria that incorporated OSCE into their training education. Because when I did my midwifery in 1984, there was nothing. So the first time I was posted to the school, and I was posted as a clinical instructor, and because I was asked to teach us, they were just and they said, yeah, because the principal then is seated right there, Mrs. Albi. And I said, please, I need materials. What you asked me to teach, but I've never heard of it. They say materials, you have to develop materials for yourself. That was the beginning. I started looking for people that we could float and write this book together. Any material, but you remember that was in 2003 when I was posted to school. I finished my midwifery in 1984. So 2003 I was sent to the school. Now, I started looking for materials. You remember that then there was no net, no internet or whatever. And OSCE is not in mice. Mice is our Bible. It's the book midwives use. So it was really a serious case. And I'm not actually collecting information from the senior midwives. And I'm glad they were there. You know, with time, they will leave and they will leave. So I started thinking about it. So for 13 good years, okay, 12 years last year, 12 years I was gathering this material. And I'm glad because I saw a lot of strength in the place where I was. That is FCT School of Midwifery, I saw weakness, I saw opportunities, and I saw threats. And I decided to use the opportunities against the weaknesses and against the threats. And something very good came out of that. And that is the book called Fundamentals. Yes, I'm happy. Let me just, someone is already within it. And that is what came out from that research, I will say, this book. And I'm glad this book is here today. Yes. And what is, let's quickly look at it. Yes. OSCE, like we see there, is structural clinical examination, objective structured clinical examination. That's OSCE. Can you quickly go? That's that. Then we are quick. I just want us to quickly look at it, how it is being used. I know we all know it. Because this material is a resource not only used by students. I found myself among students. And I said, I want to raise astute midwives. I don't just want to raise midwives that don't know their parents. I want to raise astute midwives. And I have to put on record that these are the kind of midwives I want to raise. And they know it. And I'm glad. Now, the introduction, like I said, the O stands for objective, the S stands for structure, and the C stands for clinical, and the E stands for examination. Can I have the next slide, please? This OSCE or material tool that is being used, adopted by the Nursing and Midwifery Council of Nigeria, and I believe all over the world, we do OSCE. I know those OSCE companies also do OSCE at home. OSCE has some attributes. One of the attributes, some of the attributes as you can see, are all there. The dice tool that is being used is empirical, is also used in skill proficiency and manual dexterity. It is not just theoretical one. There are so many questions that I ask you during the lab. No. We encourage our students to practice manually. We observe them demonstrating what they have learned. That is manual dexterity there. And again, the scope is very wide. It covers all content, like you could have had, all what you have seen, FDM and all these things. We try to pull all these ones when you are doing OSCE. You collect your materials from there, assess your student in all way round. So in OSCE, you'll be able to achieve all these ones. Also, we use qualified and competent personnel. during the exam to examine the students so that they can get the accurate result from the student. You don't just pick anybody. Like I told you, if I were asked to go and examine OSCE 2003, I would have come because I didn't do it during my time. Because OSCE also started it in 1991. That was when OSCE was introduced into midwifery. So I won't have been able. So in selection of those that we examine OSCE, they should be well prepared personnel that should do this so that they can get the best out of the students. Also, it would be wrong for personnel to be the one now during the examination to begin to learn. I remember I was sent somewhere to examine students. And it was not just exam, it was not just being a chief examiner. Now I was taking somebody through it who said she has never been, she has never conducted such an exam. It becomes very difficult and she may not actually come out with a good result to such students. So it's better you have personnel that have already been taught and have learned about it and teach it. Next slide, please. So there are various steps in developing it. When you want to develop, because it's expensive, it's not that cheap like you think. It's expensive. You have to sit down on the committee and find out on the wide scope, you take all that you needed as you see there. Next slide. Then you have to make some marking schemes. You have guided skills, so you are not going to rate the students outside what is in the marking scheme. And all students are going to pass through the same process, so it's highly standardized and it's valid. Yes, next. In OSCE, we value space management because you know they are going to work clockwise, and then you ensure that you have enough space so that the candidates will not be hearing what the other one is saying and we move around in the circuit. Yes. Personnel and management, patient management was yes. Open to the next one. We have the examiners, the clients or the patients, and then the time plan and share. These are all the personnel that are needed. And sometimes we use both them. But when we use clients, we have to take care of them and make sure you don't use. Particularly, we are dealing with mother and sometimes babies, not just one. So you don't, leave them for a long. Don't use them over a long time. In OSCE, you do one first round and continue, depending on the number of patients, students. So when you handle live clients, you have to really consider their comfort. Yes. Next, examiner's responsibility. The chief examiner arrives a day before then, commencement of the exam, and make sure that everything is in order. And then other examiners are carried along, and instructions are normally given according to nursing council, nursing and midwifery council, and these instructions are followed. All right. At the final exams, there are projects, there are client care projects that are always looked at to also use in grading the candidates. Yes, next slide. That is what you will see when they are going for OSCE. You see them on the line, and you can see these are some of the students seated here, some of their seniors. Yes, next. Now, stations in OSCE, they have two stations. You have the procedure station, so called interactive, and the question station, the non-interactive station. Yes, next slide, please. We normally have 6 stations, 12 stations altogether, 6 interactive and 6 non-interactive. Next. Okay, these are all the questions that will be there. Any form of question will be there. The non-interactive stations, you will always have them in numbers like 2, 4 to 12. Okay? And then let's go to the next one. And then it's a continuation of non-interactive. Then the interactive one. Go to the next. Okay, sorry, interactive one is not the interactive one. Will be the station where the students will talk, will be talking with the patient. You don't talk to the examiner has the marking scheme and just marking. It's not going to talk to you in any form. So it's just assessing you. Yes, resting station. When you have more patients, more students, more than 12, because 12 should go in particular time, you have a resting station so that you'll be able to maximize time. Yes, next please. The movement when set is clockwise. Next, the Bible worksheet. We have a Bible. so that you'll be able to now talk. If you felt the student or the candidate did not perform like you expected, or you felt you did a mistake, you know you couldn't talk because you're not supposed to talk. During the Bible, we will bring those items and say, okay, now do that selecting of paper you talked about, let me see you again. Or, okay, now describe the pelvis again, let me see you again. You'll be able to put it right immediately. Next. This is an example of what you see when you have worked out your questions, your exams. You can put them in this format and put the marks so that the person that is the chief examiner can at a glance see what you have, the various stations, and then the Viva, the marks for Viva, various stations will be 60 or more, Viva, you put in their 10 marks, then the continuous assessment, especially if they are from the school. Thank you very much. The next one says thank you, okay? The next one says thank you. I appreciate your thanks.
I wish we had enough time, but of course we've all done very well. Madam is coming for her presentation, but just before that, let me announce that this will be a very last presentation for today, and then we will let you in what will follow next as to how we're going to go for lunch. At this point, let's listen to Madam Mufi and speak to us. It's 3 minutes.
She wants, and I believe that we can give it to them, only just as
putting a step forward, adding more to whatever we're doing. So I put up that this is next slide, please. And I had to like put a little bit of philosophy of what I think everybody knows, what is the concept of care, and how it affects or how we live with it in maternity care. So I would have, there's not enough time, but I wanted to like make a little bit of talk on this topic. How I think there's three major things we as healthcare, as midwife, should actually emphasize on in order to improve in Nigeria. Next slide, please. This is some of my pictures of what I do. This is as of February in Warri Council, FCT here, where I donated up some of these fetal doctors. So I realized that in order to actually give these women some care, why don't you give them the joy of listening to their babies? Because it's a first step. They all want to know why their babies are planned. And this is another step of you trying to reduce mortality in Nigeria. So I actually donated out some fetal doctors with my money. I did that on my own self. I stayed out in Warri and visited. I spent 3 weeks in Warri Council. I think Togo, phase 1, some of them, and even the Warri General Hospital. So I spent time with some of the midwives. I trained them a little bit on how to use the doctors, taught them about how to use it, give them some lectures on consent and decision making. So this is some of just the, and these are some of the women. I wasn't opportune to have any delivery, or I hope one of the days I'll have delivery. So these are some of the women and pictures. Next slide. So, I looked at this slide is trying to make you to understand what a woman and a midwife relationship is all about. You are the professional who are extra line, and she is the client. There's a servant and serves. You are the midwife, you are there. And also be a partner to her, as well as being an expert and also a partner to her, and most especially being a friend. So we midwives were an extra led in everything we're doing. Like the other speakers say, we are the front line of everything we're doing, and we have to always make sure that we emphasize that the relationship we have with these women are always important. Alright, coming back to why I think it matters, especially here in Nigeria, in my experience I think I had, I looked at 10 points. I looked at the women, these are what the women want from you. The women want you to advocate for them. They want you to be there for them. Most of the women I saw are quite vulnerable. Most of them don't even know what they really want, and they actually want you to tell them what they want and how to go about it. So I thought about emphasizing on advocacy and also making these women to understand that informed decisions are important. They actually look up to you as the midwives to give them this pointer. Respect as well. They want you to respect them. They also want you to actually value. They want to see value your skills in promoting normal birth. They also want you to support and work together, because it gives them joy to know that your colleague, that as the two midwives are there looking after them, it gives them joy to understand that you and your colleagues are working together to give them a healthy baby and a healthy lifestyle. And also being courageous and also using the right words at the right time. And also listening to them and also being engaged and doing. And most especially in that situation where they want you to know that there's 10 ways to be silent for them to actually have a time on their own. Next slide, please. I want to conclude this by saying that the views and experiences of women and their families and communities are fundamental to the planning of health services in all countries. And always go back home and remember that every woman needs a midwife. Just few. Just few. Always have that in mind. Needs it also.
Can we please give them another resounding applause? Thank you so much. Thank you. Tomorrow's session starts by 8 a.m. 8 a.m. 9 a.m. But 8 you should be seated, that's what we're saying in essence. Just a few announcements. You should be seated. Let's take a few announcements as to how we'll go with the lunch and then we will dispatch them again. Thank you. Questions? Okay, let her finish her announcement.
Good afternoon, everyone. Good afternoon, everyone. Because I was just telling somebody at the back that it is so impressive how our energy level has been sustained the entire day. So I think midwives are powerful people. That's all I can say. Because you're facing the stage, you cannot quite feel the energy in the room. From behind the interaction, you have sustained it, you have engaged the speakers, and I think you've done phenomenally well for day one of the International Day of Midwives 2016. So please applaud yourselves again. Now tomorrow, like Andy said, is your actual day, right, Madam President? Congratulations. So you've done your registration today, so really you don't need to be here at 8. But it would be absolutely beautiful if you can be seated by 8:45. That way, and stretch your back a bit, stretch your legs, wake up properly, but try and let's start on time. We have no reason not to start on time tomorrow. And you have your programs in your bags, right? You can see it's a full lineup. And you are the only reason why we will not start on time if you are not here. Now, having said that, please remember to pick up your name tags. We had to do that, but it's beautiful that maybe by the time we end this year, we will start focusing on ICT, because we laid a lot of emphasis on pre-registration. Those things make work a bit easier. But if nobody has an idea that you are going to be at a conference, it makes it difficult to plan for you. So now that we have your names, we have name tags ready, but that will help you enter the room tomorrow, since you have already registered. So please remember to collect your name tag from the registration desk, so that tomorrow you're not filling any paperwork. It's just if they see your thing in front of you, then you walk into the hall. It would be easier for us. Lunch is served. There is enough food for everyone. But we've decided to split it in two so that we are not using one long queue and the afternoon will be over. So Madam President here, who came all the way, will lead all our beautiful speakers who've done so well, all our partners, because it's an entire networking session that you need to go, but they need to keep talking to themselves. So Precious, please can you come this way, because we're about to end for the day, so that they can see you. They're going with you into the meeting room where